Hello, and welcome to this McKnight's Home Care webinar, Fueling Your Engine with Enteral Nutrition, Making Wise Choices Around Hydration and Feeding. I'm McKnight's Home Care editor, Liza Berger, and I'll be your moderator today. Our presenters are Beth Lyman, a nutritional support nurse consultant, and Carol Ireton Jones, a nutritional therapy specialist. I'll be introducing them more at length soon. First, a couple housekeeping items. If you are having audio problems with this broadcast, please first check the volume control on your machine. This is the most common cause of hearing problems. Also, we will have time for a Q&A session near the end of the presentation. If you have any questions for our presenters, please feel free to write them out and submit them directly to us starting now. Those we don't get to in real time will be answered afterward. I'd like to note this webinar is made possible by Cardinal Health. Please learn more about them at cardinalhealth.com. And the session will be archived and available on demand shortly after the live broadcast. You can access it again, or others can experience it for the first time simply by going to the registration page to enter the studio. The URL is mcknightshomecare.com/061124webinar. Now to our presenters. Beth Lyman is a nutrition support nurse consultant. She is a senior nutrition support program coordinator with 39 years of experience in nutrition support nursing, specifically 10 years of adult and 28 years of pediatric experience. Now a consultant skilled in nutrition assessment, she has developed a plan of care and monitors effectiveness of nutrition interventions with emphasis on issues related to venous access and enteral access devices. She has worked with inpatients and outpatients who require specialized nutrition support. She functioned as the nurse on the interdisciplinary nutrition support team. Lyman is the immediate past chair of an international effort focused on nasogastric feeding tube placement verification, the new opportunities for verification of enteral tube location. She is the current chair of an Aspen-sponsored work group on low-profile balloon gastrostomy tube placement verification and the co-chair of the GEDSA Clinical Advisory Board. Carol Ireton Jones received her PhD and master's degrees in nutrition from Texas Woman's University. Her undergraduate degree in nutrition and dietetics came from Texas Tech University, where she received her clinical training. She developed the Ireton-Jones equations for estimating energy requirements in hospitalized patients, and these are widely used nationally and internationally. She provides outpatient nutrition care for people with GI disorders, including IBS, gastroparesis, and IBD, as well as those who require home parenteral and enteral nutrition. She continues to measure metabolic rate as an important part of determining individual energy expenditure in many diverse types of people. She has lectured extensively nationally and internationally on a variety of nutrition topics. She recently completed the second edition of Outpatient Nutrition Care, GI, Metabolic, and Home Nutrition Support in November 2023. The book is available from CRC Press and available on Amazon.com. So, Carol, enteral nutrition, specifically hydration, is a very important and complex medical subject. You and Beth today will break down the clinical aspects of it in the home care setting for our audience. Is that right?
That's right. Thank you so much. I know I am pleased to be here as Beth is, and we'll just take this over. Here are our disclosures for you to see, and also a statement from Cardinal Health, who is supporting this today. Well, let's get started with the objectives. So this is to be focused to patients, caregivers, and healthcare providers. We want to provide evidence-based knowledge so that you have the confidence to optimize treatment and do this safely for patients receiving enteral nutrition. So today we're going to focus quite a bit on enteral nutrition and also who might need additional fluid supplementation. We'll talk about how to build a plan, especially related to blenderized tube feedings or BTF, which you'll see later as we go forward. And then we will, in summary, show you the impact of adequate fluid intake and how blenderized tube feedings may actually influence quality of life. Well, I think that we all know that water is an essential nutrient Needs do vary according to body size, cardiac and kidney function, and activity level. Also temperature, and certainly this lecture is being done at the start of summer, and some people are already experiencing a very hot summer. So knowing that water intake will be important. Water intake is important also for patients who receive home enteral nutrition. So it's important to realize that these patients or consumers need extra water in addition to what is given in their formula. As you probably already know, women are around 55 to 60% water, men around 60% or more from water. And water is so important, it's essential to every cell. It's essential to things even as simple as saliva production, all the way to lubrication of joints. Now I'm going to start with this. Beth is going to follow up because she is a pediatric specialist in addition to adults. But I thought I would just start this with the first question being, okay, we need fluid. How much do we need? And I'm going to go over here to adults. Baseline is 30 to 40 milligram per kilogram per day, and that is a dry weight. So that's your usual body weight, your dry weight. So 30 to 40 milliliters per kilo. I often will start with 30 mil per kilo and go up for that from there. For elderly adults, 30 mil per kilo is where we often will find the best level for them for fluid recommendations. It's important to note, as you see in this highlighted slide or component of the slide, that the reason why we make these goals is we're trying to cover normal losses, GI losses, any additional losses, and create a minimum of about 1 liter, 1,000 milliliters of urine output per day in an adult. Beth, would you like to cover pediatrics?
Yes, thank you, Carol. Welcome, everyone. We're glad to have you on today. In pediatrics, there are 2 formulas that we use. The first one is the Holiday Seeger, and you can see it's 100 mils per kilo. And then this, for the next 10 to 20 kilos, it goes up, and then finally over 20 kilos. Or the 4-2-1 method, 4 mils per kilo per hour, 2 mils per kilo per hour for greater and for anything greater than 10 kilos, and so forth. The bottom line is that in pediatrics, we start with maintenance fluids, and we go up from there. Now, in this, both of these calculations is the concept of free water, and I'd like to define free water for you. It is not something you get out of the tap, and therefore you think it's free. It is sodium-free water. And so it's water that does not contain sodium, and therefore theoretically it can go anywhere. It can be extracellular, intracellular, go into the brain, the eyes, things like that for synovial fluids, for joints. And the other thing we want to think about is that in children, the body's surface area is so much higher than in adults. And so they can actually lose fluids much more quickly than an adult through sweating and things like that. And finally, the thing that I would want you to keep in mind, and you'll hear this more than once from me in this talk, and that is that the rate of the need is as important as the change. In other words, if they need a lot more fluid, the rate of that need, the losses, whatever they're doing, vomiting, having diarrhea, is as important as the change itself. And the next slide, we look at sources of fluid in home enteral nutrition. And so I'll kind of start this off in pediatrics, and then Carol will take it from there. But in pediatrics, infant formula, I'm sure if you provide pumps for pediatric patients, you have some babies. Infant formula, we call it 20 calorie per ounce, 22 calorie per ounce, 24 calorie per ounce. So it's how many calories per 30 mils. So there's a lot more free water in infant formulas, and therefore we don't worry as much about free water at all in infants. In fact, we do not give them water, additional water. Now, pediatric patients, their formulas are 1 calorie per ml, just like what Carol has on here, a conventional enteral formula. And in adolescents, we would use adult formulas. And now Carol's going to talk about other formulas as well and sources.
So this is a rule of thumb for a patient that you may have on an enteral feeding. 1 cal per ml formula, maybe sometimes now they're 1.2 calories per ml. They're going to be somewhere around 75 to 79% free water. What that means is that once you've calculated the fluid need for your patient, then 75 to 79% of that is going to be provided by the enteral feeding, which means you must provide the rest in some other way. And we'll talk about that in a little bit. If you have a patient who has a more concentrated formula, this is kind of similar to what Beth was mentioning with the pediatric patients, but 1.5 to 2 cal per ml. So these are patients that may need to have decreased, a more concentrated formula to get in more calories. Then these are 70 to 75% free water. So it's important to notice the difference between these based on calories per ml. Now, next is blenderized tube feeding, which are homemade versus commercial. So homemade blenderized tube feedings, some of us who've been in practice for a very long time, that could be Beth and I, very much remember homemade blenderized tube feedings. This is what was used to make tube feedings for years ago. It's often being used now. And it's difficult when these are homemade blenderized tube feedings to estimate how much fluid is in those. So we have to be very careful that we observe for signs and symptoms of dehydration. And certainly, as mentioned previously, making sure that urine output is appropriate. Now, commercial blenderized tube feedings have product information on the label. And so for these, the 1 calorie per ml is probably around 81%, 1.5 cal per ml, 76%. So there's a difference between a blenderized tube feeding and a conventional enteral feeding. But both of these, we have to be aware of how much free water is in these, and then what we need to provide to the patient. So there's some consumers that might need extra fluid. I'm going to take the adult side for a moment. Physically active. One of my home enteral nutrition patients has known to climb mountains. He's a skier. You name it, he does it. He's physically active. So he requires additional fluid. Outside in the hot weather, again, additional fluid. If there's high ostomy output, high stool output, or diarrhea, vomiting, even chronic fevers, those are patients that may need additional fluid. And we threw in some specific diagnoses here because I know many of us are seeing patients with postural orthostatic tachycardia syndrome and others. So some specific diagnoses may have additional fluid requirements. Now, is it so different for pediatric patients, Beth?
Well, no, it isn't. The only thing I would say is that the predominant diagnosis for a child who requires home enteral nutrition is neurologic impairment. And because of that, many of our children are not physically active. They're actually wheelchair bound or even bedfast. So they're not as physically active. The one thing, caveat, that families need to know, and sometimes I tell folks like you these kinds of things because you're the ones talking to the families and kind of reinforcing things that perhaps were said in the hospital and possibly forgotten, is that they're going to take these kids outside. They're going to take them to soccer games. baseball games, because the siblings will be playing in those sports. And so if they take a water bottle for the child that's playing the sport, they need to take a water bottle for the child that's in the wheelchair that's going to be watching it. And then neurologic storming, we have patients that are hypertonic and have neurologic issues, things like that. So no, other than that, it's really not very different.
Now, you saw on both of these blenderized diets. So this is a great slide, and one that you can find at this resource that is part of this slide. And it's options for commercial and home blenderized tube feedings. The reason why we wanted to show you this is to help you to understand that our patients that are receiving home enteral nutrition may be receiving a standard commercial enteral feeding. They may be receiving a commercial blenderized tube feeding, or they may be receiving a home blenderized tube feeding, or they may have made a combination of all. So this is kind of a great pro and con description of these, so that you can share this with your patients, or they may already have looked at this, but for you to know that if they are using a combination, it may make your understanding of their fluid requirements a little bit more complex. So be aware of this. But there are ways to give more fluid. I'm going to let Beth take this.
Right. And so as a nurse, we would deal with how we were going to give fluid, and we did not have access to automated pumps, but we would use a syringe. Now, in pediatrics, typically what we will give is no more than a couple of ounces. And this obviously relates to how large the child is. Like for an infant, no extra water. But then for a pediatric patient, say 2 or 3 years old, we may give an ounce of extra fluid or 2 ounces 4 times a day. The older the child, the more likely it is that we may have to go up to 4 ounces in between feeds, which becomes a problem with patients and families forgetting that 4 ounce in between the feeds. When you have an automated system where there's an enteral pump giving formula, and every now and then either a water flush or a water bolus, it allows both the families, and then if it's in a skilled nursing facility, the nurses, to make sure that water is given and not have to worry about it. And there's a really good study I'm going to talk about coming up about that very topic. So this study done in Italy was on stroke patients, and the issue of them all needing a tube feeding, but having problems with clogged tubes. And like I said, as a nurse, clogged feeding tubes are a real problem, and you don't want to have to pull out a tube on a patient that had a stroke and have to put another one down because they have a problem with their gag reflex anyway, and things like that. So the subjects were randomized to either get manual, meaning someone went in every 1 to 2 hours and gave a fluid flush, or automatic flushes. And and they were looking at tube occlusion, but they found something else as well. So the manual flush, as you can see, they had 7 patients out of the 31 that had a clogged feeding tube, where the automatic flush patients, there was only 1 patient. Now, here's the kicker. 10% of the patients in the manual flush actually got the manual flush. So, and I think we need to be very clear about the fact that if we need patients to receive extra fluid, and it's that important that they get it, having a pump that just gives it is going to have a higher instance of success. Now, in pediatrics, we had even the worst problem of small bore tubes. And so, having patients that had clogged tubes was a bigger problem for us in pediatrics. But let me tell you, as a nurse, this whole thing of flush the tube every 4 hours, you have to know it's just not happening for the most part, which is a sad comment, but it is true. And so Carol's going to talk about blenderized tube feedings a bit, and I have some comments on a pediatric study as well. Go ahead, Carol.
Great. And just to follow up on what you mentioned about the occlusion of the feeding tube with the lack of flushing, it can be a problem because the tube has to be replaced, and it is also a delay or no nutrition for several days, which can be quite a problem for these patients who may be at nutrition risk. All right, let's talk about blenderized tube feedings then. So blenderized tube feeding considerations. First is the nutrition composition. It's macronutrients and micronutrients. And micronutrients include vitamins, minerals, even electrolytes. Also fluid, also fiber. Then as this may be developed, maybe it's the family's food. So the family makes their food and they blenderize that food for their family member as well. There's been some research in this recently, quite a bit, more and more as these are more common, and comparing a homemade blenderized tube feeding with commercial formulas. Blenderized tube feedings have been typically shown to be lower in energy and carbohydrate, but adequate in fat and protein. So this is where it's really important to have the expertise, Beth would agree with me, of a registered dietitian to help plan the composition of this blenderized tube feeding. Now, some of these blenderized tube feedings may be associated with bloating, nausea, constipation, GI symptoms that may be associated with food. So again, this could be a place where a skilled dietitian can help. But there have been subjective reports that when a patient is able to develop their nutrient composition, their micro and macronutrients based on foods that they know they tolerate, there's been improvement with blenderized tube feedings. But we have to have careful monitoring because of the variable composition, monitoring fluid intake and adequacy of the diet. So paying attention to whether the patient is receiving all of their nutrition. This is why on the previous slide, a couple back, patients may do a combination. So on a day where they can do a great job and blenderize their feeding, they do that. But if they're in a rush, going out to an appointment, they may use a commercial feeding or a commercial blenderized tube feeding. So this monitoring is very important, and also helping them to understand that they can make decisions that combine multiple types of enteral feeding. Can blenderized tube feeding be provided via a pump? That's a common question I get. Beth?
Yes, it can be. I just want to talk a little bit about the previous slide. I want to go back to it for just a second because let's see, that's not the one. Okay, there we go. They're about blenderized tube feedings because Carol is, from a pediatric standpoint, everything Carol said is absolutely correct. But I want to talk about one study. It's by Gallagher from Sick Kids in Toronto, it's called the Blend Study, looking at blenderized diets that were developed by dietitians. And 20 patients. And the issue was what happens to the gut microbiota and how are symptoms for these child? How do the caregivers perceive the symptomatology of the children? And so this outcome of this was that, in fact, the caregivers very much perceived that the child tolerated the tube feeding better, had much less GI symptoms, GI intolerance with blenderized tube feedings, and sensed that their quality of life was better. And in fact, many of these children went on to be able, they were in intensive oral therapy as well, and they were able to transition to some oral intake, and the parents felt that it was because the children kind of got the feeling or the taste of food, and that helped them to enjoy that when it actually was placed in their mouth. But the other thing that was so interesting about this study is that it proved that the blenderized tube feedings provide a very diverse and more healthy gut microbiota. And the gut microbiota, the bacteria in the gut, very much influence motility. And in other words, whether or not the gut functions properly and the child, has stooling, proper stooling and things like that. So that's kind of a big deal in pediatrics. And most of you probably know this whole blenderized tube feeding thing that we're going through right now. It is not a fad. Blenderized tube feedings are not going away at all. It started in pediatrics. So yes, let's talk about this study here by Mariah. Very well done, published recently, just the end of 2023. And what they looked at were enteral pumps used to deliver blenderized tube feedings of varying thicknesses. Their hypothesis was that the thicker the formula, the less accurate the pump. And in fact, in clinical practice, we would have parents tell us that the pump would say, and formula delivered, the dose was delivered, when in fact there was 1.5 ounces of blenderized formula still left in the bag. So we saw that in our own clinical practice. So they looked at 6 blenderized tube feeding of varying thicknesses, and they either ran them at 50 mils an hour or 200 mils, like a bolus, over 30 minutes. And we did a combination of this. And in fact, in that study that I just quoted you from Canada, half the subjects were bolus fed, a third of them were pump fed, and 15% were actually got both. They did a combination of both. So this is a very similar and real life simulation for using a pump and a blenderized tube feeding. And in fact, what they found, okay, there we go, is that indeed the pumps they studied actually gave 22.5% less formula if there was a moderate and very thick blenderized tube feeding. And so the other thing that they found in kind of on the side, just like I was talking with the manual flush study, on the side, they found that indeed 7 to 30% of the product is left in the container after the family, they tried to get it out. And so this is very important because we really need to have people use calibrated cups to measure. So when you're working with families and you're introducing them to the pump that you're providing, they need to know they should pour that out into a measuring cup. And then possibly if that child gets a water bolus after the blenderized tube feeding, put 1 ounce of that in the container, swish it around and put that out. They also found, and we saw this in clinical practice, that there was no alarm that said that the feeding wasn't going in when there was blenderized tube feeding left in the bag. So this is an important thing. The 3 pumps that they looked at were the most common used in pediatrics. So it's something to really think about. Now, so this is a study that shows the complexity of hydration in pediatrics all the way around. So this is a study from Boston Children's, and they looked at different blenderized tube feedings, and for kids that got over half of their total intake from tube feedings, and they were about a little over 3.5 years of age, but they ranked from 12 months to 18.7 years, which tells you, the audience, that we are using blenderized tube feedings in much younger children than we did when we first started. But what they found was that their hypothesis was that blenderized tube feedings are better tolerated because they're thicker. And because they're thicker, there's less reflux and all of those kinds of symptoms that go along with reflux. So the blenderized tube feeding, that's why there's so much content from adult and pediatrics in this talk, is because blenderized tube feedings use is on the rise, and they purposefully do not have a lot of liquid in them because they think that clinicians, I am one as well, think that the thicker the formula, the better tolerated it is by the child. Okay, so these kids got an additional 320 mils average per day of additional water besides their blenderized tube feeding. So the issue was that the less water they got, the fewer respiratory symptoms that they had. And that's what they were looking at, is do they need more chest x-rays? Because reflux aspiration is very common in the population for which we are using blenderized diets. So the more water they got, the more likely they were to have aspiration and reflux. Now, the question, of course, you have is the aspiration from oral secretions or is it from the stomach? And they did not answer that as a retrospective study. But that's why we don't want to have folks just make blanket statements about how much or adding more water or anything like that without going to the healthcare team, because this is a very complex thing. And it may be that the child needs a bolus of water in between the blenderized tube feeding, because many of the parents I worked with refused to give more than a couple of ounces of extra water with a blenderized tube feeding. They said their child had symptoms when they did that. So now let's look at quality of life. When a child has adequate hydration, their lights are on. And I know that sounds really very glib, but it isn't. And you know exactly what I'm talking about. They realize a lot more about their environment. They are aware, they are able to enjoy television, interacting with families, things like that. They have better formula tolerance, and the caregiver has a peace of mind of knowing that their child is getting adequate fluid and nutrition. And in the same way, then they can give more time to other family needs. And this is a saying that I learned in pediatrics, and I say this is a truism. When your child's doing better, you do better as a mother. Now, quality of life and hydration is a big deal. And I want to talk a little bit about lack of hydration and the symptoms and why it is so important that this seminar even occurred. Children that do not get enough fluid don't have the ability to communicate that for the most part. The signs are very subtle. They just kind of start just going into a zone where their eyes glaze over, they don't have many tears, and they don't have much saliva. Well, sometimes we dry up their saliva. Their urine gets dark and concentrated while they're in diapers. So the symptoms of dehydration in children are what I call symptom overlap. They can be signs of other things as well, needing to take a nap, not being as active because they're just tired, things like that. So we need to be very careful in observing the child, and prevention is key. And that's the purpose of this talk, is we need to prevent dehydration, and as opposed to trying to chase our tails and always treat it. And then again, the rate of change is as important as the change. Now, Carol's going to talk about older folks and quality of life.
I am, but I want to also go on, add to what Beth said on the previous slide, and it is pertinent to this as well, because while adult may be able to tell you, yeah, I feel a little dizzy, or I haven't had a lot of urine output, or I'm tired, I'm exhausted. They may be able to tell you that, but the older adults, our seniors, may not be able to tell you this. And yeah, as Beth mentioned, I think she said, the lights are on when they're well hydrated. And actually, with dehydration, cognitive function does decrease. And that can be something that is seen in our older adults. They have fewer reserves in their tissues. They have less response to thirst. I'm sure you've seen that in practice. They already may have decreased kidney function, and they may be taking medications that actually cause increased urine output, which may lead to dehydration. So the treatment is actually prevention, making sure that the amount of fluid needed is actually provided. And as Beth mentioned in her pediatrics discussion, it might be as part of the pump, or it might be outside of the tube feeding. And then adding to additional fluid to account for unusual losses. One thing I also wanted to mention when it comes to quality of life is the older adult, any adult, can actually sit with the family while they eat. And if they have the blenderized product that the family is eating, that can be certainly a factor in quality of life. Okay. I like this. Wait, what about sports drinks and electrolyte solutions? So what should we do? Well, this is useful in someone who may have very much increased needs. So a patient who has high urine output, maybe a patient who has short bowel syndrome, who is receiving a tube feeding. This could be a pediatric patient, could be an adult. But it's important to evaluate these to determine if these would be helpful. So what are the components of a sports drink or an electrolyte solution? Well, they have some sodium in them, and they have some glucose, and they're isotonic, which means that they're well tolerated. Must have some sodium because that will help the water to be absorbed. Must have some glucose that will also facilitate absorption. So if you have a patient that has increased losses, you find that they are not really getting what they need with additional water. This is where talking to an expert, your clinicians, can help you with maybe looking at a sports drink or electrolyte solution that could be helpful. I don't know if you wanted to add anything to that, Beth?
No, we do not use these types of formulas to give additional water, but in many blenderized tube feeding recipes in pediatrics will start with an oral rehydration solution. Many of those will.
Yes. All right. So in summary, home enteral nutrition formulas, both commercial blenderized tube feedings and home blenderized tube feedings can provide adequate macronutrients and micronutrients, and they provide some fluid, but we must be sure we provide adequate fluid and monitor for hydration status. And I saw this little guy online and I thought, I kind of like that. And of course, don't count on thirst as your key driver of hydration. And with that, that would be my summary. Beth, would you like to add anything before we turn it over?
So, well, I think the purpose of our conversation today is that we don't expect you to treat hydration problems. What we would like you to do is realize there's evidence to support the fact that home enteral nutrition patients need extra water and when they might need extra water. Because I know as a longtime clinician, many of my families contacted their durable medical equipment dealer, their home care provider, someone outside of the hospital first, about a problem, and then the person there said, call them and tell them this. Call Beth and tell her this. And that is what we are hoping you will get, is how you can help the families anticipate problems and frame a concern that then they take to their healthcare provider. And we really and very much enjoyed our time with you today. And I think Jennifer is now going to speak.
Thank you. My name is Jennifer Woolley, and I'm a global medical science lead with Cardinal Health, as well as a registered dietitian. I hope you can see that with the conclusion of the education portion of today's Lunch and Learn, that supporting high-quality educational programs like today's webinar is very important to Cardinal Health. And on behalf of Global Medical Affairs, I would like to provide a short overview to illustrate how we place the patient, caregiver and family, and the healthcare professional at the forefront of all of our medical device innovations. We understand that to a patient, dehydration, prolonged malnutrition, or a clogged feeding tube may increase the risk of short-term and long-term complications that can interfere with quality of life, and take that into consideration with the design of our enteral access devices. We've listened to the concerns and needs of caregivers and families in terms of the importance of minimizing feeding disruptions in daytime activities or rest at night. We've heard the voice of caregivers that complicated equipment is stressful and have transferred their feedback into the design of enteral access devices that are intuitive and easy to use. We recognize that healthcare professionals want to do everything within their power to nourish patients safely and improve clinical outcomes. And with these outcomes, we recognize that there may be struggles with clinical staff due to limited time and resources to ensure that optimal patient care is being delivered at all times. It's our goal at Cardinal Health to offer effective tools to achieve long-term success with enteral nutrition in both hospital and home care settings. Our latest enteral feeding pump is designed to adapt to a patient's changing needs through the care continuum, from hospital to home and beyond. The advanced features and robust technology of this enteral feeding pump make it versatile, portable, and easy to use in meeting the nutrition needs of a variety of patient populations. Versatility allows the accommodation of individualized feeding prescriptions for both enteral feeding and hydration across a variety of care settings. We've received feedback that portability is a big priority for patients and families who desire an enteral access device that goes wherever they go. This pump operates in any orientation. It can be placed in a backpack, on a table stand, or on an IV pole, and has a 20-hour battery life for plenty of time between plug-ins for activities such as appointments, work or school, and travel. Cardinal Health is dedicated to making enteral access devices that are easy to use regardless of patient location or care setting. With our latest enteral feeding pump, the feeding cassette audibly clicks into place with one hand. A large color LCD screen display and step-by-step prompts with animated illustrations efficiently guide pump operation. Our new pump has technology that promotes precision medicine with a plus or minus 5% accuracy of delivery with standard enteral formulas, and has the ability to store up to 30 days of feeding history to track the patient's prescription adherence over time. One more example of intelligent design is the ability of this pump to administer thick formula, also known as blenderized tube feeding, with plus or minus 10% accuracy of delivery. We've heard about thick formula, blenderized tube feeding today, but I want to reinforce that the trend to blend is increasing in a variety of clinical settings and patient populations. As Carol and Beth said, there are two major types of blenderized tube feeding, commercial and prepared. Commercial being a formula that's manufactured with food or pureed ingredients that are prepackaged for use, whereas prepared blenderized tube feeding is a formula prepared in a home or hospital blender with food ingredients or pureed foods for individual use. Both must be prescribed and monitored by a healthcare professional. But what's important about blenderized tube feeding when administered through a pump is how thick or viscous it is to ensure that it can safely run through a feeding tube without clogging it. Cardinal Health defines thick formula as enteral fluids of consistency that are categorized as level 2, 3, or 4 drinks within the International Dysphagia Diet Standardization Initiative, IDSI, framework. That means that we're talking about drinks that are ranging from thin to slightly thick, including mildly thick, moderately thick, all the way up to level 4, extremely thick. But it's important that these thick liquids are smooth and consistency or are homogeneous without any lumps, chunks, or seeds. You may ask, well, what's IDSI? I've never heard of that. IDSI is an internationally recognized organization that quantifies the thickness of various foods and drinks. And this is particularly useful in the enteral nutrition realm so that the viscosity of various enteral formulas can be quantified. If you would like more information, please visit idsi.org detail. In closing, before we move to the question and answers, Cardinal Health is committed to providing patients, caregivers, families, and clinicians global access to nutrition-related content as well as resources. To learn more, please visit the Kangaroo Learning Center at mykangaroolearning.com. These are my references. Thank you, and I'll turn it back over to Liza.
Thank you very much, Jennifer. And thank you also very much to our speakers, Beth and Carol. Now is the time for the Q&A. So if you have questions for any of our speakers, now is the time to type them out to us. We do have some questions in the queue, so let's get to them. First question, someone said, I find this guidance confusing. Pump does not alarm, infuse whole feeding, and do not deliver via gravity. This indicates to me no pump, no manual gravity. So how do we administer? Beth, Carol?
I'm going to turn that over to Beth because I think that is but I think that's a fabulous question, and that is a question that could easily come from any of our consumers. Beth, what do you think?
Well, it is a confusing situation. The real issue is that if you have a pump, if the patient has a pump that is not delivering the formula, the blenderized tube feeding, in the amount of time that the family wants, then what we would do are a couple of things. Add more water, which then, according to the Hirsch study, and we in fact saw it as well, there could be more pulmonary problems, or there could be problems with GI intolerance, or you increase the rate on the pump. Any way around it, if you're purchasing pumps, look at that Mariah study before you purchase a pump. I encourage you to do that, or listen to what Jennifer had to say, because it is a problem. And some families would go to bolus feeds. The problem with bolus feeds is that with a blenderized tube feeding, you cannot just let that just go right in. It's just like eating a meal. You need to eat a meal over 20 to 30 minutes. You need to give a blenderized tube feeding over 20 to 30 minutes. And that's why they get put on a pump, is because the families, nobody has time to stand there and do that.
Interesting. Okay, let's go to our second question that's in. What about allowing the adult or elder to take some blended meal in the mouth for taste, etc.?
So that is a great question. And that all depends on anatomy and the patient's problem. If they have dysphagia, if they have a swallowing disability, then that is absolutely not an option, unless you feel like they could put a little bit in their mouth and then spit it out, because I have a few patients who actually eat a little bit of food by chewing it, but they never swallow it. So if that could be done, I think that would be reasonable. It all depends on the level of cognition that your patient has. Also, if it's a stroke patient, you're working with someone who has speech therapy training, they might be able to tell you, well, all right, one amount of this food that is appropriately thickened might be okay. But the stroke patient I mentioned, that is the guy that climbs mountains and skis and does everything else, he can't even swallow his own saliva. So it very much depends on the patient's diagnosis. Beth, any comments?
No, but in pediatrics, that question came up regularly. And it really, the speech pathologist runs the show on any oral intake. Now, in that Hirsch, or the one study that I talked about, and I think it was Hirsch, but they looked at, no, it was the Blend study by sick kids in Toronto. They used kids that they thought had potential to do oral intake, and they found that when they used blenderized diets, that they were able to progress more on oral intake, because food refusal is very common among children with neurologic impairment. That's it.
Yeah.
Okay. That's another question. There are many different opinions of max water flush from the dietitians at my facility. Do you care to weigh in on this, either of you?
I'm just going to start, and then I'm going to let Beth go ahead with this. I think that putting it in a cup measure helps people understand what that amount is. It's very similar to starting a patient at 20 milliliters per hour. And then when you actually put that in a fourth cup measure and you go, oh my gosh, that's not very much. That's when you realize exactly how much that flush is. So my answer would be, it very much depends on individual patient tolerance and need. Beth, comments?
Yeah. So if this is about safe water flushes, in adults, it can easily be way more than 8 ounces if they do not have issues with delayed gastric emptying, lower esophageal sphincter dysfunction, things like that. But it can easily be way over 250 mils. The real issue is, should you be giving water flushes to an adult that are more than 8 ounces? And why would you be doing that? So that's kind of where I'm at with that. In pediatrics, we would say for kids that were on blenderized tube feedings and needed extra water, that they got 4 to 6 ounces. That was the max. In between, not after, in between feeds.
This same person asked a couple related questions: max water flush before and after meds, and max water flush in general, which you may have addressed.
Well, as a nurse, the max water flush before and after meds is a big deal in adult nursing, because a lot of these patients that are on tube feedings get liquid meds. And so the water that is used with liquid meds dilutes the concentration, the sugariness of it, and can actually prevent dumping and cramping and things like that. So if you're giving liquid meds, and a lot of them, then you do need to add water, and you may end up giving say if you have 30 mils of potassium chloride, you need to dilute that with at least 45 mils of water. Now, because of the osmolality of that potassium chloride, the problem is if you're giving 5 liquid meds, you're going to end up with 400 mils of water. And so my stance on giving liquid meds with flushing before and after liquid meds is that you separate out these daily meds and give some at 8 in the morning, noon, 4 p.m., things like that. And you give those meds with a feed to help dilute them out. Always give the meds first and then the feed. But that's a problem with liquid meds. So flushing before and after is more an issue of trying to protect the gut from the osmolality of the medication. And I know that nurses are to flush before and after every medication. I don't see a lot of that happening in clinical practice.
And I agree with you. And I think if for your patient that you just mentioned that now he's going to have, or she is going to have over 400 mils of flush, we've got to make sure that this person is sitting up in their wheelchair or sitting up, not lying back in bed, lying back on their recliner. They really need to be sitting up after this. And sometimes that gets forgotten in the scheme of things. So that's something I would say as well.
Yes, very important.
I would like to say yay for the dietitians who are asking questions, because it's absolutely an area we need to be intimately involved with. Not everybody gets a great nurse to hang out with like I do with Beth, but often we're both on our own having to answer questions for the others. So good for you. Good for this multidisciplinary approach.
We do have another question from someone who works in a long-term care facility, and she's wondering if you can share current guidance about checking tube placement.
Okay. Yes. So if you're talking about a nasogastric tube and placement, the standard of care for adults oftentimes is an X-ray. But if you don't have an X-ray, we use pH as the standard of care in pediatrics because we don't want to expose our children to so much radiation exposure. If you're talking about gastrostomy tube placement verification, that standard of practice is being defined now by an international interdisciplinary group of emergency physicians, surgeons, gastroenterologists, interventional radiologists. It's a group I chair with Aspen. And so that's being defined. But what I will tell you is that if it's a routine gastrostomy tube placement, Carol McGinnis published an article in Nutrition and Clinical Practice about putting grape juice down the existing gastrostomy tube or some colored beverage of some sort. Even a colored Gatorade would work. And then you put the new G tube in and pull back the fluid. And if you get that same color fluid, then you're in. And I have used that on adults that I've taught how to self-insert NG tubes in themselves at home that can swallow safely fluid. I'll have them drink some Gatorade, put the NG tube down themselves, and then see if they can get Gatorade, the color back. So I hope that helped.
This is Liza. I'm back. I temporarily lost my internet, but I am back, and I think we have time for one more question. Would you care to weigh in on this question? I work in a long-term care facility and wondering if you can share current guidance on checking tube placement. Obviously, this is
I just did that. Yeah, I answered that one.
I apologize. Okay. Yeah, and then any tips troubleshooting for dealing with slow clogged feeding tubes? You have about 30 seconds. Did you do that one?
clogged feeding tubes. Okay, I'm going to just go out there on a limb, and I'm going to tell you the study that we were working on at Children's Mercy when I retired, but they never did it. And that is putting apple cider vinegar down the tube. And it's like Italian salad dressing. It's not going to kill the patient and put them in some kind of acid-base disbalance, but you could use about an ounce of apple cider vinegar in about 20 ml syringe, back and forth, and let it dissolve the clog. Work like a charm on everything except anti-seizure meds.
Wow, great tip. Great tip. Okay, well, fortunately, we've come to the end of this very informative webinar. I hope everyone has enjoyed it. It will be available shortly at mcknightshomecare.com/061124 webinar. I'd like to give a very special thank you to our fabulous presenters, Beth Lyman, Carol Ireton-Jones, and Jennifer Woolley. I want to thank our sponsor, Cardinal Health. You can learn more about them at cardinalhealth.com. Thank you all very much for tuning in and for your great questions. This is Liza Berger for McKnight's.